Hello, my name is Neil Chandreka. I'm a transplant nephrologist and chief of renal medicine at UMass Chan School of Medicine. Today, we're going to be talking about transplant board review, and this is my background slides. And these are my disclosures. So the objective of today's talk is really to highlight common questions that may come up in the board review, and these will be different issues, including cross-matching, delayed graft function, rejection, and donor and recipient evaluation. So let's go on to the first case. I'll read the case, and then I'll go through the different potential analyses. Gout after kidney transplant, which one of the following is true? A, is commonly associated with the use of tacrolimus. B, is usually treated with non-steroidals. C, if allopurinol is prescribed to a patient on mycophenolate, the dose of allopurinol should be reduced. D, use of allopurinol with azathioprine needs careful monitoring. Or E, colchicine is contraindicated in transplant patients. So the correct answer is D, use of allopurinol with azathioprine needs careful monitoring. So A is not true. Gout is actually can be associated with cyclosporin. It's rarely associated with the use of tacrolimus. In fact, it used to be fairly common practice that if a patient was being treated with cyclosporin maintenance immunosuppression, that if you switch them to tacrolimus, it would have a beneficial effect on the gout. B is obviously not correct. We wouldn't use non-steroidals in a kidney transplant recipient, but especially so because of the vasoconstrictive effects from non-steroidals would be worse with a patient on a CNI, which also causes vasoconstriction. C, if allopurinol is prescribed to a patient with MMF, the dose of allopurinol should be reduced. That is not correct. There is no interaction between MMF and allopurinol. E, colchicine is not contraindicated in transplant patients, although you may have to dose reduce if the GFR is lower. The correct answer is D, and we'll go through that answer. So when azathioprine is absorbed, it's then broken down into 6-mercaptopurine, which then can be can go through 3 different pathways. It can be broken down and inactivated through 2 pathways: the xanthine oxidase and the thiopurine methyl transferase pathways. So when somebody takes azathioprine, it's really distributed between these 3 pathways, and the active pathway, which goes through a series of different metabolites, but then increases the amount of white cell apoptosis, decreases white cell replication, and leads to myelosuppression. Now, if you concomitantly give allopurinol, the allopurinol can inhibit the xanthine oxidase pathway, which shuts more of the azathioprine and its derivatives into the pathway that is active, thereby increasing the effect on the white cells. If a patient has a variant for the TMPT gene, they can actually inhibit the TMPT pathway, which again shunts the azathioprine down into the active pathway and makes it more effective, if you like. So a patient who's on allopurinol and on azathioprine and happens to be homozygous for the variant of the TMPT gene that causes inactivity, then they can have very significant myelosuppression. So in patients who are on azathioprine and allopurinol, it may be wise to check their TMPT gene profile, or at very least make sure that you monitor them very carefully for allopurinol and azathioprine activity. And that can really be done just by checking the white count frequently after starting the treatment. So the second case, a 66-year-old male is admitted 3 weeks after uncomplicated deceased donor kidney transplantation with increased serum creatinine. Although he feels quite well, he notices some reduction in urine output, mild pain over the allograft. His medications include mycophenolate, prednisone, tacrolimus, valganciclovir, and Bactrim. 2 days prior to admission, his creatinine was 1.5, and the tacrolimus trough was 9.4. Today's creatinine is 2.3. The pre-transplant T-cell cross-match was negative, and the allograft functioned immediately. He received immunoglobulin as induction therapy. His medical history includes ESRD secondary to IgA nephropathy. One previous transplant was lost after 6 months from severe rejection, BPH, and hypertension. On examination, his pulse is 80, his blood pressure is 150/90. He has mild tenderness of the allograft site, but his examination is otherwise unremarkable. So the question is that initial management should include all of the following except tacrolimus trough concentration, B, check for single antigen anti-HLA antibodies, C, ultrasound to rule out allograft hydronephrosis, D, empiric IL-2 receptor blocker, e.g. basiliximab, or E, ultrasound to exclude urinary leak. The answer is, of course, empiric use of an IL-2 receptor blocker. So there are two reasons for this. The first is that we really don't want to be treating patients empirically without making a diagnosis. And secondly, even if you thought that the patient had acute rejection, you wouldn't really treat them with an IL-2 receptor blocker. That would be used for induction therapy, but isn't really a good agent for treating rejection. Thymoglobulin is used both as induction and can be used for treatment of severe cellular rejection or resistant cellular rejection. So this is the case continued. His initial test showed that tacrolimus trough of 6.5 and WBC of 4.5, hematocrit of 30, platelets were 160. Urgent ultrasound shows no hydronephrosis, no perinephric collection. Anti-HLA antibody testing is pending. So which of the following is the next most appropriate step in management? A, check CV viral load. B, increase tacrolimus dose. C, reduce tacrolimus dose. D, empiric steroid pulse. Or E, allograft biopsy. So as we already discussed, it's imperative to really make the diagnosis as quickly as possible. So particularly in a case such as this, where the patient has previously lost an allograft due to rejection, you want to diagnose the rejection as quickly as possible. And really the only way of doing that definitively is to do an allograft biopsy. All the other treatments may be correct, but it depends on what the diagnosis is. So an uncomplicated biopsy is performed. Light microscopy shows no tubulitis. It does show neutrophil capillarities. Staining for C4D is positive in the peritubular capillaries. Single anti-HLA antibody testing shows previously detected anti-HLA antibodies, but no donor-specific antibodies, no DSA. But which of the following is true? The diagnosis is recurrent IgA nephropathy. B, the most likely diagnosis is acute polyomavirus infection. C, even though there is no DSA, plasmapheresis is a treatment of choice. D, allograft nephrectomy is indicated. Or E, the diagnosis is cell-mediated rejection. So the correct answer is C. So even though there is no DSA that is currently present, treatment of choice is plasmapheresis. So let's go through why that's the case. Well, the reason A is up there is that IgA nephropathy occurs very frequently after transplantation, but it is rarely causes significant graft dysfunction. If the case of IgA nephropathy in the native kidney disease, in the native kidneys, was very severe or very rapidly progressive, there's a higher chance that the patient may have recurrent IgA nephropathy of significance in the transplant. B, when it comes to acute polyomavirus infection, it's possible, but the biopsy doesn't really show that. And the diagnosis, would show an acute interstitial nephritis if he has BK nephritis, and the SV40 staining would be positive. ED, allograft nephrectomy is obviously not indicated. E, the diagnosis is cellular-mediated rejection, which is not true. So let's talk about antibody-mediated rejection. Antibody-mediated rejection resulting in graft dysfunction is estimated to occur in around 3 to 10% of all renal transplants these days. The rate of antibody-mediated rejection has gone down significantly, and it is unusual in patients who are not sensitized to transplant. It's estimated that as many as 30% of acute rejection episodes have some degree of antibody component, and it's very important to carefully examine the histology in patients for any evidence of antibody-mediated rejection. It's also important to note that antibody-mediated immunological processes pretend a worse prognosis. So it's been reported that there's a 40 or 50% graft survival for C4D positive patients compared with 8-year graft survival patients who are C4D negative. The C4D staining is an important indicator of prognosis in patients with antibody-mediated rejection. It has also been reported that 1-year graft survival of 65% occurs graft diffuse C4D positive staining compared to those with only focal or negative C4D stain. So, which one of the following is not included in the diagnostic criteria for acute antibody-mediated rejection? A, pleuritis. B, fibrinoid necrosis. C, diffuse positivity of C4D staining in the glomeruli. D, donor-specific antibodies in the recipient serum. Or E, histological findings of ATM. Well, the answer is C. So remember, the C4D staining needs to be in the peritubular capillaries, not glomeruli. If it's present in glomeruli, that is not diagnostic of antibody-mediated rejection. All the others are compatible with the diagnosis of antibody-mediated rejection. These are diagnostic criteria for acute antibody-mediated rejection. This goes from increasing severity from the top to the bottom. One thing to note is that a biopsy that only has ATN is in fact compatible with antibody-mediated rejection without necessarily the other histological markers of AMR. And that often occurs in the early transplant setting, particularly in patients with delayed graft function, where they can't have antibody-mediated rejection, particularly if they're not sensitized, and the histology may only show ATN. You can read all of the other histological characteristic features. And of course, C4D staining, as already stated, is diagnostic if it occurs in the peritubular capillaries. And identification of DSA is also compatible, but not absolutely necessary for a diagnosis of donor-specific antibodies. So, with the question that we posed, why would plasmapheresis be helpful if there's no circulating antibodies? Well, the reason is really twofold. And the first is that the antibodies could be taken out of the circulation very quickly and may not be detected, but be present in the allograft, because the allograft will act like a sink for these antibodies. And part of that is seen when you have patients who have transplant nephrectomy and their circulating antibody levels will go up significantly in some cases. And that's because, as I said previously, the DSA is actually probing in to the kidney, and the kidney is active at these antibodies. So pheresis is still an indicated treatment for these patients. So when we see preformed antibodies, they basically bind to the endothelium of the vessels within the kidney, and then they recruit complement and PMNs to the site. This increases inflammation and increases the risk of thrombosis and graft loss. The antibodies shouldn't be directed against HLA. It's also possible that they could be directed towards other antigens. If there are non-HLA antigens, the degree of rejection is often not as severe as you'll see with antibody-mediated rejection directed against HLAs. Hopefully, we are not doing ABO incompatibles without knowing about it, but ABO incompatible transplants can have hyperacute rejection because of the preformed antibodies to the ABO system and from the recipient directly against the donor. So we can see in this slide the polymorphonuclear leukocytes in the peritubular capillaries, and you can see this here on the right-hand side. And this is typical of antibody-mediated rejection. Sometimes we'll see an increase of lymphocytes in this area, which is also compatible, but PMNs are more characteristic of antibody-mediated rejection. You can see an increase in the number of cells within the glomeruli in antibody-mediated rejection here on the left, or we're showing an increased cellularity in the glomeruli, which predominantly neutrophils and macrophages. If the antibody-mediated rejection is severe enough, what you will see is a picture of fibrinoid necrosis within the arteries and complete obstruction of the tiny vessels. When we see C4D staining, you may not be able to make this out on the right-hand side, but these are, you can see the tubules and the peritubular capillaries lining the tubules, which are lighting up with the C4D staining. And this is characteristic of antibody-mediated rejection. What you're seeing here is not really the antibody, because the antibody will bind to its target, but the antibody will be broken down, and what you get left is the antibody disappears. What is left is complement. But this is really more a split product of complement, which is C4D, which becomes covalently bonded to the tissue. And that's why it shows up on the C4D state. And this is a novel protocol biopsy which shows C4D staining. So mycophenolate mofetil, which of the following is correct? A is inhibits lymphocyte IMPDH, thereby reducing lymphocyte synthesis of RNA and DNA. B is associated with fewer GI adverse effects than azathioprine. C, trough blood concentrations are routinely used in guide dosing. D is nephrotoxic at standard doses. E rarely affects proliferation of non-lymphocyte cells at standard doses. So the answer is A. Iosine monophosphate dehydrogenase is a target for mycophenolate, and that reduces the synthesis of RNA and DNA. And because lymphocytes don't have salvage pathway, it predominantly affects lymphocyte function. GI side effects are quite common with mycophenolate. Up to 30% patients will have GI side effects. Azathioprine does not have GI side effects and is often used as a substitute in patients who have intolerable GI side effects in mycophenolate. Although studies have shown that mycophenolate is superior to azathioprine, and in patients who are unsensitized and who are placed on high-dose azathioprine, and the rates of rejection are not dissimilar between the two drugs. Although blood concentrations of mycophenolate can be measured, they are not routinely used to guide dosing, and there's a great deal of variability with these levels. And D, obviously, Michael is not nephrotoxic. That is the calcium inhibitors. And E, really affects proliferation of non-lymphocyte cells and for the reason that talked about. And so this slide basically reiterates what I just said. And so mycophenolate is very lymphocyte selective at standard doses, but it can cause marrow suppression and anemia. And sometimes that is a reason for an indication for switching the patient off market. Next question. For living donation, in which of the following conditions would donation be considered to be okay? A, donor with a history of gestational diabetes. B, donor with a history of kidney stones in the preceding 2 years. C, donor age is less than 18. D, CT angiographic evidence of donor with bilateral fibromuscular hyperplasia. Or E, heterozygous for APOL1, the high-risk genotype. And I think actually we already have the answer highlighted, it is, of course, and that's E. So in terms of the answers that are not correct, A, if there's a history of gestational diabetes, that person has a 50% risk of developing diabetes later in life. So generally we avoid patients with gestational diabetes. B, stones, we obviously do not want to increase the risk of stone formation once there's only a single kidney. The donor age of less than 18 is a contraindication for donation. And D, obviously, if there's angiographic evidence of bilateral fibromuscular dysplasia, you don't want to be using that individual as a donor. APOL1, I'm sure everybody knows about APOL1 now. There are two disease-causing variants, G1 and G2. And if you're homozygous for either of those variants, or you have two copies of a high-risk variant, meaning G1/G2, there is an increased risk of kidney disease. Being heterozygous for a high-risk variant, i.e., just having one copy, and does not increase your risk of kidney disease. 1 in 3 African Americans will be heterozygous for a high-risk variant, and therefore it's not we considered to be a risk factor for donation. Next question. Which of the following conditions can reoccur early after transplant and reoccurs frequently, i.e., greater than 40% and causes loss of the lung? A, IgA nephropathy. B, membranous GN. C, MPGN. D, FSGS. And E, lupus nephritis. So the answer is FSGS. So FSGS can occur at different ages, but when associated with kidney disease in younger patients, pediatric cases and younger adults, there's a significant risk of recurrence in the allograft. IgA nephropathy does frequently reoccurs, but is often very mild and doesn't cause significant graft loss. Membranous GN can reoccur, and it's often patients who are positive for PLA2R at the time of transplant are more likely to have recurrence of the membranous GN, but it doesn't necessarily, they don't necessarily need to be PLA2R positive. MPGN can recur, but often does not cause the same degree of graft loss. And same with lupus nephritis. So here's the estimated rate of recurrence of these different disorders. And as you can see, FSGS recurs around 30% higher in younger patients. If you have older patients diagnosed as FSGS, particularly if it's not primary FSGS, and obviously the rate of recurrence is not as high. Which patient needs to wait the longest disease-free before getting their transplant. A, 64-year-old basal cell carcinoma 1 year ago. B, 34-year-old female with cervical CIS 2 years ago. C, a 55-year-old male with acute C colon cancer 4 years ago. D, a 67-year-old smoker with lung cancer resected 3 years ago. Or E, 58-year-old female with DCIS 3 years ago. So the answer is D, 67-year-old ex-smoker with lung cancer resected 3 years ago. So here are the guidelines for cancer for waiting periods prior to transplantation. So even though these guidelines are from 2005, little has really changed with these recommendations. And I won't read through this whole list, but you can see that there are recommendations for the waiting period post different cancers. It is interesting that some of these cancers may not really recur at the rates that we have previously thought. And certainly uterine cancer has not been shown to recur at a higher rate in transplant patients, and neither has ovarian cancer. Which of the following donor characteristics is generally not considered a contraindication to living donation? A, patient with blood pressure greater than 140/90 with mild hypertensive retinopathy. B, age less than 18 years. C, BMI greater than 40. D, a horseshoe kidney. Or E, a 6 to 8 HLA antigen mismatched with the potential recipient. So the answer here is E. Blood pressure of 140/90 may not be a contraindication in itself, particularly if the blood pressure can be controlled with one, or in some cases, two antihypertensive agents. It depends on center's policy. But the evidence of any end organ damage, such as retinopathy, would be a contraindication. Obviously, less than 18, we've already discussed. A BMI of greater than 40 is a relative contraindication. There are some centers that will take patients with a BMI of greater than 40, but generally the cutoff is a BMI of 40. D, obviously, you don't want to take kidney from somebody with a horseshoe kidney. Next question. A CMV negative recipient receives a zero mismatched kidney from a CMV positive donor and is prophylaxed with valganciclovir. 2 weeks post-transplant, she develops fever. Which is the least likely source? A, CMV. B, wound infection. C, UTI. D, common cold. Or E, pneumonia. So the answer is A, CMV. So the patient is on prophylaxis, which is very effective at preventing CMV disease. In fact, most of the early infections post-transplants are bacterial, as you can see on this figure. The viral infections tend to occur a little bit later, and the longer-term infections, the typical infections, Cryptococcus and nocardia, tend to be a little bit later as well. So in a case like this, it's probably the most common things. UTIs are particularly common early after transplant, as is wound infection. Next question. Which of the following is not a common side effect of tacrolimus? A, neurotoxicity, tremors. B, hypertrichosis. C, islet cell toxicity. D, hyperkalemia. Or E, hypertension. So the answer is B, hypertrichosis. If you compare the two CNIs that we use, the side effects generally overlap to a great degree. However, hair loss is common with tacrolimus, and hirsutism is common with cyclosporin. Gum hyperplasia is not something that you see with tacrolimus. It used to be quite common with cyclosporin, particularly with higher doses, and particularly when given in patients already taking nifedipine. The other thing thing to note is that tremors are more common in patients with tacrolimus. And although they can occur in tacrolimus, it's unusual that you'd see tremors in patients. Next question. A 56-year-old female patient is 8 days post-deceased donor transplant and has a slow-functioning graft with creatinine 3.8. She's taking tacrolimus and mycophenolate. She has mild hypomagnesemia and is hypertensive at 170 and 90. She presents to the ED via the EMT with generalized tonic-like seizures. Which of the following is false? A. Antiepileptic medications are indicated. B. Magnesium repletion is necessary. C. Tacrolimus should be discontinued. D. Treatment includes increasing the tacrolimus dose. E. MRI should show white matter changes or may show white matter changes. So the answer is that which of the following is false, that treatment includes increasing the tacrolimus dose. What we are potentially seeing here is a case of reversible posterior leukoencephalopathy or PRES. And this is thought to be a condition that includes disordered cerebral autoregulation from endothelial dysfunction. And it results in hypomagnesemia, hypertension, and renal dysfunction. It's seen with immunosuppression in transplant patients, more commonly with tacrolimus, but it has been reported in patients taking mycophenolate as well. It's also seen in patients with sepsis, preeclampsia, or treated with cisplatin. The MRI will show symmetrical white matter edema in the posterior cerebral hemispheres, particularly in the parietal occipital regions. And clinical and radiological findings are reversible with the treatment of exacerbating factors. So the treatment is immunosuppression reduction, and generally related to tacrolimus, stopping the tacrolimus as a first line, as that is the most likely agent. And also with the use of antihypertensive agents, withdrawal of offending drugs, short-term treatment, antiepileptic drugs, and magnesium. Next question. HLA molecules normally A, present foreign antigens to T cells, B, present foreign antigens to B cells, C, present foreign antigens to both T and B cells, and D, have nothing to do with antigen presentation. Well, the correct answer is, of course, they present foreign antigen to T cells. And this is a cartoon just as a reminder of how antigen presentation works. There are basically two pathways of recognition of foreign antigens. One is called a direct pathway, and the other is indirect pathway. The indirect pathway is the way that your immune system normally responds to foreign antigens. And here, the allogeneic peptide derived from the transplanted tissue is processed into peptides and presented on MHC, on an antigen-presenting cell. This is recognized by the T cell, and this leads to an activation of T cell, which then can trigger various different pathways, such as cytotoxic T cell activation or production of antibodies by B cells. And that the direct pathway also is thought to act as a mechanism for recognizing foreign MHC in a transplant recipient. And here the T cell directly is recognizing the allo-MHC molecule with some peptide attached to it. And this occurs early after transplantation, and this response reduces with time as the allo-antigenic presenting cells become decreased in number and eventually disappear. Then this leads to an equally, this leads to the same pathway of T cell activation. B cells do not recognize peptides of allo-MHC on MHC. They recognize foreign antigens in their native configuration. Next case, 51-year-old African-American female had an uncomplicated living donor kidney transplant. The donor was a husband who has the G1, G0, APOL1 genotype. Historic DSA has been positive, but pre-transplant cross-match is negative. She was diagnosed with FSGS and APOL1 high-risk homozygous phenotype. Immunosuppression has been thymoglobulin, mycophenolate, pathogen, and tacrolimus. Creatinine quickly fell to 1.2, and she has a medical history of lupus, hypertension, and peripheral vascular disease. 3 months post-transplant, she was admitted with serum creatinine 4.9. The medication was mycophenolate, penicillin, tacrolimus, and valganciclovir. Blood examination and blood pressure was elevated at 180 over 95, no papilloma. Allograft was non-tender and otherwise unremarkable. Ultrasound showed no hydronephrosis with a resistive index of 0.6, which is not elevated. The creatinine went from 1.9 to 2.3, and the tacrolimus level is 11.2. Urinalysis is unremarkable. It's a protein. The white count is 1 to 2.2, with eosinophils 4 to 15%, but the absolute number is normal. Hemoglobin is 9.1, platelets of 200, and so which one of the following is not in the differential diagnosis? The answer is recurrent APOL1 related kidney disease. So this is an area which is probably the story hasn't fully come out. There's a risk of allograft failure in kidneys, in transplanted kidneys that come from from donors who have the high risk APOL1 genotype. In other words, people who are homozygous for G1 or homozygous for G2 have the G1/G2 phenotype. And that has clearly been demonstrated and probably is the cause for why kidneys from deceased donors who are African American may not survive as long as kidneys from non-African Americans. Transplant recipients who have the high risk APOL1 genotype do not have an increased risk of early allograft failure. Whether there is an increased risk of late allograft failure is still something that is more controversial, and there have been contradictory papers published on this, but generally is not thought to be associated with early allograft loss. So the same patient, the next best test to determine the etiology of acute allograft dysfunction is 1, flow cytometry cross-match against donor cells. B, kidney biopsy. C, CT angiography of iliac and transplant arteries. D, blood CNV viral load. Or E, serum C3, C. Well, the answer obviously is the kidney biopsy. So the next question, the mononuclear cells underlying the endothelial of the small artery are most consistent with, and this is really what I'm to show you that. A, acute antibody-mediated rejection. B, mild acute cellular rejection. C, polyoma nephritis. D, severe cellular rejection. Or D, or E, arterioembolism. So the answer is D, severe cellular rejection. So the reason for that, the important point here is that we always tend to think of vascular injury as being associated with antibody-mediated rejection. It, of course, can be associated with severe cellular rejection, so you shouldn't forget that is a potential differential diagnosis. So the patient had a biopsy, which was read as an acute cellular rejection to an AAC negative, cross-match against donor T and B cells negative, LDH haptoglobulin smear for schistocytes was negative, and MRA showed plaques in the aorta, no stenosis, the common iliac renal artery, and steroids were used in the thymoglobulin. 3 months later, So the diagnosis of acute cellular rejection, which resolves with treatment 3 months later. She presents with increase in the creatinine from 1.8 to 2.5. Medications are the same. Kidney biopsy performed and C4D staining is negative. And this is the biopsy. And what you're seeing here on the low power is these purple patches, which are aggregates of cellular infiltration, and it corresponds with a lymphocyte infiltration. And this is a higher power, which shows these are densely packed lymphocytes in this biopsy. And, this is the immunostaining with SV40. And of course, if you see that in the exam, SV40 is polyomavirus simian virus 40, which is a member of the polyoma family and cross-reacts with BK virus. So if you see this staining, then obviously it's an indication that the patient has BK nephropathy. And here you also see the enlarged nuclei, which are typical of patients with BK. So the most common biopsy findings are consistent with, of course, the answer is C here, BK nephritis. And this is not atypical in a patient who's been treated with significant immunosuppression, cellular rejection, or even antibody-mediated rejection, and then develop BK nephritis due to obesity. This is EM, which shows you the viral particles. Of course, this is necessary to make a diagnosis of BK nephritis, but this is what the individual particles look like. So BK nephropathy, well, BK is reactivated and it is reactivated from the uroepithelial cells, and it is related to high dose immunosuppression and ischemia. It most often occurs between 4 weeks and 1 year post-transplant. Patients obviously screened, and then for BK viremia at time intervals post-transplant. And histologically, you make the diagnosis done with the typical histological findings, interstitial nephritis, and SV40 positive staining and biopsy. And treatment is reduction of immunosuppression, but IVIG and mTOR is very useful. And then the cytotoxic T cell lines and BK specific immunoglobulin is being tested as potential therapies as are small molecules BK, but as of yet, they are not approved treatment. So next question. All of the following factors are included in calculating the kidney donor profile in the KDPI except for. But this relates to deceased donors and how they are graded. So A, race, B, history of diabetes, C, serum creatinine, D, smoking history, or E, age. So the answer is smoking history. There are 10 factors that go into the calculation of the KDPI for the quality of deceased donor kidney, and these are age, height, weight, ethnicity, hypertension, diabetes, cause of death, serum creatinine, hepatitis C, and cardiac death. And the KDPI is used to measure the organ quality, and you have to allocate deceased donor organs. If you have a high KDPI of 5, then it is viewed as a high KDPI kidney, or what we used to call the extended criteria, or marginal kidneys. And that is a separate waiting list which patients have to consent to be on. And these organs are usually allocated to older recipients who may benefit from a high KDPI kidney. For younger patients, obviously, you want to give them low KDPI kidneys. KDPI can change because serum creatinine donor can change, and smoking history is not there as the KPDI factors. Thank you very much, and that's the end of this presentation.